This conference will now be recorded.
All right, so I started the recording for the lecture. Let's see. All right, so we're going to cover neurologic emergencies first, and then we're going to get into some other stuff after that. So we have 2 lectures today, and then we're going to do practicals, and we'll see how well you guys can assess a 5.5-year-old today.
Tell you, got myself medical. Dr. Bricks.
Nice.
I'm gonna get RSI.
That's pretty sweet. That's awesome.
We got lots of extra continuing education from Dr. Hospital and going through separate labs. It's awesome.
Yeah. All right. There we go. I'll go this way here. I can't see my screen at all. There's a big line right through the middle of it. So obviously we're going to talk about the standard competencies. So looking at what medicine is, what we do, and trying to assess and find findings for the acutely ill patient. Same thing we see every slide that we talk about. But really what we're looking at is neurology. So we're going to look at different things to as far as decreased level of responsiveness, seizures, strokes, things that can cause an altered level of consciousness, head injuries, trauma patients, status epilepticus, headaches, TIA strokes, seizures. A lot of these things can be caused from neurological issues in the brain. And we'll talk about that more in depth here. So stroke is the 5th leading cause of death and the leading cause of adult disability in the United States, which is common in the geriatric patient. We see a lot of stroke patients. We go to a lot of calls where they have stroke-like symptoms from repeat falls at home with head strikes causing a hemorrhagic stroke, so a head bleed, to just the occlusive strokes we look at as well, patients that have AFib that are throwing clots. We have all these different things that we come in contact with that we're going to see. And most of the stroke patients that we see are mostly the elderly patients we get called to. When you're that charter level, stroke-like symptoms are showing positive on the stroke scale, and they call them through dispatch. So when they do emergency medical dispatching, they're actually going through the Cincinnati stroke scale, which is what we would do going into a residence. And they'll say positive evidence of a stroke. If dispatch is coming across saying that kind of stuff, we need to understand that that's most likely what's happening. They check for slurred speech, facial droop, and then they do arm drifts. So they may have them do this. Arms come up, palms out, and see if one falls or not. Yes. Yep. So those are some of the conditions you might find out there that mimic the strokes, and we'll get more into that in a little bit on those. We also have the facial droops. You'll see one side will come down versus the other. So you want to have them smile, and if one stays up, one comes down, or stays down, you look for that affected side. And then we'll have them do speech as well. So it will come out like garbled. So they might ask them to say, like, you can't teach an old dog new tricks. And by saying that, it's allowing for all the facial muscles to be utilized. So when you're having them repeat that after me, you can't teach an old dog new tricks, and they can't say that if something doesn't come out. Another thing you might find also is the patient is very aphasic. They're not going to be able to get the words out. So they're going to be like, well, how are you today? They're going to go, purple. What? You know, they want to say something, but something else completely comes out, or their words to come out very garbled, or they're just rambling on different things. And it makes absolutely no sense what you're even talking about at all. Those are more of the stroke patients you're going to come in contact with. Just like a stroke. Yeah. With this also, treatments are available for stroke, but many hospitals are certified stroke centers. So like around here, we don't have certified stroke centers. Those stroke centers that are going to be doing the clot removal are going to be more of your neurological centers like Portsmouth Hospital. They're a stroke center. The local hospitals are still stroke hospitals because they have the ability to do head CTs and be able to give clot busting things like TPA. So they can do that kind of stuff at the local hospitals, but if they're doing that, they're going to be transferred to a neurological center like Portsmouth, Maine Med, Dartmouth, Concord, you know, ones that can take stroke patients versus the local hospitals like you look at Huggins Memorial. If they get active strokes, they do, like I said, they do the CT to rule out bleed. If there's no bleed, then they can progress with going with a thrombolytic like TPA. So again, it's going to be all part of the process. They also have the availability at these critical access hospitals to have what they call teleneuro. So if you bring in a stroke alert to Huggins, what's going to happen is you're going to call in early with a name, date of birth, that starts registration stuff, and also gives them the heads up. Hey, we're coming in with a stroke. We're going to be there in like half an hour. During that time, if you're working at the desk, as Alyssa knows many times, yeah, you start making phone calls, and the phone calls are going to your neurologist, and they have a set of teleneuro. So as soon as you come through the door, we as ambulance crew recognize the fact that we have a stroke in hand, and we bypass the ER, go right to CT. As they come out of CT, you go back to the hospital room. There's a neurologist on a telescreen doing a video conference with that patient right off the bat. There's no delay.
Why not MRI?
MRIs take too long. So they want to do a quick head CT, and what they're looking for, and they put in as like a stroke CT. So over there, the radiologists know they have to actually read it quickly over at Dartmouth. So they do the quick review, and they also send it over. Once the review's been done, they send it to the neurologist to look at, which could be the last one I went to was Florida. That's where we're talking with the neurologist from Florida. That was one of the last guys that I was dealing with. And they have a conversation with the patient. There's a whole NIH stroke scale, they call it. They have a whole flip chart thing they use. They ask them questions to having them move legs, arms, touching their nose, visual checks, sensation checks, and then they have a pictogram stuff they look at. So you have to be able to pick out what these items are and what's wrong with that. Yeah.
I have an ALS assessment button. Do I have to do that? I thought that might have.
Hold on 1 second.
This conference will now be recorded.
All right. So again, rapid transport for these stroke patients are vital because they have a time frame that we look at, and the AHA is 5 hours from the onset of symptoms. So when we're doing our assessment, we need to find out the last known well or last known normal time, because we got to figure out when they were last seen before these symptoms started, which is hard to tell because if they went to bed at 7 p.m. and they woke up at 9 a.m. or 7 a.m. the next morning and they have stroke-like symptoms, when did that start? So sometimes there's nothing that even the hospitals can even do. It might be too late. They're still going to ship them to see if they can do anything at a neuro center, but the ability of getting TPA or the thrombolytic that's there might not be available.
Now, how many hours?
5 hours max. It also depends on that's more of the AHA standard. Seizures and altered mental status also may occur as well. So look at seizures may occur as a result of head injury, brain tumors, a metabolic issue as well. So electrolyte imbalances, fever, or genetic dispositions. So again, this is only introduction. We'll get into more of this stuff here in a few minutes. Other causes might be intoxication, head injury, hypoxia, stroke, or metabolic disturbances. And the treatments vary very widely in what we're going to do. Everything has a different treatment, how we're going to fix it. With altered mental status, we can do a lot of stuff in the back of the ambulance, even at the EMT level. And that's just giving oxygen for those hypoxic patients. A lot of times the altered mental status just could be the fact that their oxygen level is 70%. Just give them some O2, they start coming back a little bit. Fluids, again, they may become altered because they have low blood volume. Stroke can cause that. Shock can cause altered mental status as well. So the brain is the body's computer. So everything goes through the brain, from vision to speech to sensory. All this stuff goes through the brain itself. And if anybody has a type of head injury, that can affect certain centers of the brain that cause us to do certain things. So again, like if you have a bad head strike and you hit the back of your head on the occipital lobe in your head, that controls your vision back here. So if you have a head strike, one of the questions you want to ask is, do you have any blurry vision? Any issues seeing? So I'll check eye movement. So I'll take my finger like this and I'll have them do like an H pattern. So I'll start here, come over, go up, down, and back, up and down like this. All right. That means I'm looking for good neurological movement. They can follow commands very well. I'll have them stare straight ahead and I'll take my 2 fingers. I'll say, see these 2 fingers? I'm going to wiggle them like this for you. I'm going to start here. I'm going to wiggle them until you can see peripheral visions. I'm checking all that kind of stuff. That's all occipital lobe, looking at the different division center. So we're going to do those kinds of assessments in these. So there's three major parts, obviously the brainstem, the cerebellum, and the cerebrum. And the cerebrum is the largest part of the brain. So let's go to the next slide here, as you can see. So you can see the cerebrum wraps around. Oh, what? This is even better. If it comes out. Look at this. So the cerebrum is all through here. All right. So the largest part of the brain. So you have the skull. This protects us from injury. That's the skull, the bone that wraps around. The cerebellum is located here. These are all the different lobes, which they're not going to get too much into. But you have your parietal lobe, or sorry, temporal lobe. Parietal lobe is here. Occipital lobe is back here. And your frontal lobe is up here. Each one of those helps control different parts of what we do, from bodily functions, from vision to speech to sensory to motor functions and all that kind of stuff. And then our brain stem is here, and runs straight down into the spinal cord. This controls breathing, circulation, everything that runs the brain. Okay, so if we have any kind of severe head trauma that causes any kind of herniation to the brainstem, the patient's probably going to die if they're not dead already. All right, and our spinal cord runs through here. All right, I'm trying to advance slides like this. So we looked at the brainstem as it controls most of the basic functions, like the breathing, blood pressure, swallowing, pupil constriction, as well as the cerebellum, which controls muscle and body coordination, which is walking, writing, picking up a coin, playing a piano, all that kind of motor function that's going to happen, right? Helps us control that. So if we have any kind of injury to either one of those, as you can see, this can be very detrimental to the point where they can't walk anywhere, they forget how to walk, or from the trauma. The cerebrum is also divided into the right and left hemisphere. So cerebrum here branches off, and that plays a big part. We'll talk about that in a second too, when we talk about head bleeds. Each controls activities of the opposite side of the body. So if I'm looking at the right hemisphere, that controls the left side of my body, right? If I have, left side controls right side of the body. So the hemisphere controls opposite side, right? So if you have unequal pupils and the pupil on one side is non-reactive, is kind of like dilated, the opposite side of the body is where the stroke is, opposite side of the brain. So again, controls opposite side. So if you have facial droop on the right side, it's the left side of the hemisphere that probably has a clot somewhere that's in there, or a bleed of some sort. So it controls the opposite direction. The front of the cerebrum controls emotions and thoughts. Okay, so frontal lobe, cerebrum here, frontal lobe. And then the middle controls sensation and movement. So that'd be more of your parietals here, both sides. That's your sensation and movement as well. And the back processes sight, occipital lobe. So get a chance, so know those lobes as well, because those are going to be very important for your testing coming forward. So occipital, parietal, temporal, frontal, front to front. Each one of those controls something a little bit different, as you can see up there. And most people's speech is controlled on the left side of the brain, near the middle of the cerebrum. So left side, right about here is your speech center. So you're driving a vehicle, you're the driver, right? You have a side impact, you have head injury here. What would you expect to see? Speech issues, potentially, if they have a significant head trauma, right? So we want to make sure we're asking these questions, have them speak to you. If they're coming out garbled, they make no sense. We have a close potential, and there's no open here. You don't see blood or brain matter coming out, all right? That's a closed head injury. These patients need to be treated appropriately and quickly. And a lot of times with head injuries, they're going to be intubated eventually at the hospital, depending on how bad they are, right? So we help control that breathing. So getting ALS on board for those. Messages sent to and from the brain travel through different nerves. So there are 12 cranial nerves that runs directly from the brain to the parts of the head, ears, eyes, nose, and face. So we have 12 cranial nerves. The rest of the nerves also join the spinal cord, and then they exit through the large opening of the base of the skull, called the foramen magnum. So that's that big hole we talked about during A&P initially. The big hole I was talking about, it's the foramen magnum. Each vertebra, in the neck and back, two nerves branch out called spinal nerves. These carry signals to and from the body. So if you touch something hot, it transfers through nerves into your spinal cord up to your brain and say, ouch, probably shouldn't do that. You pull away, right? So if we lose that sensory, right, then we have a nerve issue somewhere, or there's a brain injury where we don't have that sensory. So that's why we do CSM checks, right? Pulse sensor, so we check circulation, motor function, and sensory. So we have, touch, squeeze. Can you feel me touching here, here? Does that feel sharp or dull? Sometimes we'll take like a pen and we'll go like this. We'll go like that. Does that feel dull or sharp? It'll say dull. Or take a pen and I point like this. Oh, that's sharp. If they can't tell the difference between that, we have a sensory issue. There's a nerve issue somewhere. Something's not going right. And usually we check those for strokes or head injuries, things like that, because there could be a bleed, there could be a stroke in that part of the brain that's causing it, so we don't have that sensory function. That's why CSMs are so important to check on every patient. The same thing goes when we're splinting, because if you have a fracture, this is more trauma, if you have a fracture in the humerus and you're splinting it and you had good CSMs before and they're absent after that, now we've lost blood supply somewhere, okay? So we may have to, and if we lose blood supply, we have to realign that bone to get them to get back to normal. So if you look at here on the screen, as you can see, the cerebellum is located here. The cerebrum, the big part of the brain. Brainstem comes down. The foramen magnum is a big hole that runs through here. All right, so spinal cord comes down in here with his vertebrae. So we have 7 cervical vertebrae, 12 thoracic. We have 5 lumbar, sacral 5, and 4 coccyx run down. And through here, our spinal nerves come off, okay?
Breakfast, lunch, dinner. 7, 12, 5.
I like it. I've never heard of that before. I always remember it as 7, 12, 5, 5, 4, 33 vertebrae, but that's just how I remembered it, but that's good to know. You guys catch all that? Breakfast, lunch, dinner. More of a 9:30 guy, but. So the spinal cord runs through here. These spinal nerves run off, and they go into something in the dermatomes, which I'm not sure if we get into that kind of stuff at the EMT level. I can't remember off the top of my head, in the dermatomes and feelings. We can get into that a little bit later, though. Oh, absolutely. I just hope there's a diagram. If not, I'll bring it up at the end. I'll try to find a dermatome picture so they can see it. I don't know if it's taught at the EMT level or not. I think it's more advanced paramedic. Get into that. There we go. So obviously there's many different disorders that may cause brain dysfunction, right? There's a lot of different things that are out there that can cause that, from strokes to trauma to intoxication, things like that can cause any kind of brain dysfunction that are there. Many affect the patient's level of consciousness, speech, and voluntary muscle control. The biggest one that we see, though, is more head trauma and hemorrhagic or occlusive type of stroke. We see those more than anything else. But what are some other things you can think of, though, that may cause that? That can cause any kind of issues with the brain or level of consciousness changes. So drug overdose can change that kind of stuff. Okay, blood sugar. Because your body requires 3 things to stay alive, right? What are those? Right. Because if you don't have sugar, the body dies, right? If you don't have blood, the body dies. If you don't have oxygen, the body dies. You need those 3 things for the body really to stay alive. There's other things mixed in with that, but those are the 3 major components, right? I was taught that 22 years ago when I took my EMT class, and it's stuck with me all this time, that those are the 3 things the body needs to stay functioning. Without those, the body can't move, can't function. But what about infections? Can infections cause altered mental status in the brain? Right? What kind of infections are there out there that can cause that? Okay, so that's called the mental status, right? But it's not really more of a brain dysfunction. What about meningitis? Right? An inflammation of the meninges, right? So remember, the brain is sensitive changes to changes in oxygen, glucose, and temperature. So obviously, if we're hyper or hypothermic, this will also cause altered mental status as well. If you have a patient who's hyperthermic and then altered mental status is there, right? That's heat stroke. Once you see that AMS, now we're into the heat stroke phase. Okay, that's one of the big components from heat exhaustion to heat stroke is that altered mental status change. So we want to make sure we look for that. And then glucose, check a blood sugar. That's a BLS skill. All right. So that's a BLS skill. All right. Looking at that. I may have to stop the class and pause this for a minute because it's going to get very loud, I'm sure. People coming in. Obviously, then oxygen as well. So so at the EMT level, we can check body temperature, we can check glucose, we can check oxygen.
This conference will now be recorded.
All right. So as a general rule, if the problem is caused primarily by disorders in the heart or lungs, the entire brain is affected, right? The brain needs oxygen to function. So without that, the brain can't function appropriately. So we got to treat the hypoxia. So we got to look for signs and symptoms of hypoxia, right? So to look for signs and symptoms of hypoxia, what would we do? Other than pulse oximetry being low. Okay, skin color, temperature, right? What else? Cap refill, low perfusion. What else can we look for? Or even ask, do you have any difficulty breathing? Right? So we look for skin tone, difficulty breathing questions, right? That they're sitting there and they're tripoding, right? Accessory muscle use, nasal flaring for children, pursed lip breathing for the adults. Yeah, I hate when that happens. So we look for different signs of the shortness of breath that cause the hypoxia. All right. And if the primary problem is the brain, remember, it's only going to be part of the brain that is affected. So hypoxia affects the entire brain versus a brain injury, which affects a specific part that has that injury, right? And the only way you can tell true brain injury is through CT and MRI to kind of see where that damage is actually located. So headaches is one of the most common complaints. So we get headaches a lot, right? So the question is where is the headache located? What kind of headache is it? Do they have history of headaches, migraines, things like that, right? So we got to ask those specific questions. Where does your head hurt? Is it specifically to one spot? Is it all around? Where is the headache actually happening? One of the indications for a patient that says they have a severe headache would be like a head bleed, would be they have the worst headache of their life and it's like one spot. It hurts really bad right there. And my vision's being affected. It hurt. I have a headache. Sharp pains, that could potentially be a type of bleed versus someone, again, it could be a bleed the other way as well, but oh, my head hurts all through here, through the frontal lobes. Well, do you have a history of migraines? Yes. Does it feel like a migraine? Yes. Okay. Then we can start treating for the migraine. Can we give medications to help with that? Do we have any medications we can give to treat pain at the EMT level? Yes. No? I don't know. Yes. Yes, with the new protocol update in December. You guys in Maine got a lot of good stuff on the new protocol rollout for EM. The advanced, we're still being recorded. The advanced EMT has got IV Tylenol.
We're being recorded.
Yeah, I'm recording the lecture.
Oh, we'll know what that means.
I record the lectures and put them up on the YouTube channel so they can watch it later. So normally this is done through virtual, but because I couldn't see Wednesday. All right. So obviously, it can be a symptom of another condition or a neurologic condition of its own. So again, we have to do that assessment by asking them, your bright lights hurt your eyes, checking pupillary response, and things like that, right? Only a small percentage of headaches are caused by a serious medical condition. Again, it's a small percentage, but there's still a potential for that to be there. Well, you're not going to have it now. It's going to be in the new protocol rollout. So when the new protocol rollout comes out, it'll be for all levels over there. See the new washer? All right. So tension headaches, migraines, sinus headaches are the most common that we're going to see. Those are not life-threatening. They can be a pain. They can feel like their whole life is going to end. But again, they're the most common things that we're going to find in the field, and we can treat that. Now, if they have a headache and they complain of chest pain, all right, you probably don't want to be giving them nitro. That makes the headaches a lot worse. So that's one of those things where it's a medical control consultation. And it is either way for EMT level. But again, look at everything as a whole, your big picture versus just being focused on the specific symptoms that are there. Case in point, I was working with another provider who was also a paramedic. We had a patient who was literally had stroke-like symptoms and also had chest pain. He wanted to give the patient nitro. So I'm like, no, we're not going to do that. There's EKG does not indicate anything of a STEMI, so we're going to hold off on that kind of stuff.
Who was that?
I can't mention the name.
Okay.
They no longer work here. And I took the nitro and put it in my pocket and said, after the call, you can have it back. And I got in the front and drove.
Jason Love.
No, it was Massachusetts. So again, look at the big picture and not just be tunnel visioned on that specific complaint. You want to ask a lot of questions. Look at the medical patient as a whole, and what we can and can't do. All right. So again, look at everything before you start making your treatments. Get a good assessment before you start doing interventions. Now, that does not mean that if they have no airway, intervene right away, please. Okay. But when you're asking questions and they're saying certain things, I want to know more about what's going on. Tension headaches are caused by muscle contractions in the head and neck, right? So sometimes with tension headaches, I've seen them give Toradol, works pretty well for that kind of stuff. I've seen that in the emergency departments. Tylenol, if you can, they have migraine medications out there as well. I'm just trying to blank on the names, some of those that are out there for them. So if anybody has migraines with a prescription name, let me know. I can't. Botox. This is usually attributed by stress. So again, ask some questions. Even if we're doing a neurological assessment, we can still do psych assessment because I consider psych and stress all together. My own opinion on that. I'm still going to ask some questions about their lives and why they're being stressed out, so I can put that towards my assessment of how I'm going to treat the patient, right? Pain is usually described as a squeezing, dull, or as an ache in the head, and usually does not require any kind of medical attention. So the tension headaches can sometimes relieve by their own, just rest, and things like that. So we still want to make sure we find out.
I get mine, and I get Botox, but I was also prescribed some Narcan
All right.
for like onset of headaches, which I'll find like definitely.
What was it?
Huh?
What was it called?
I've seen the hospitals use Haldol before for migraines.
I get headaches. They're directly associated with my blood pressure. My blood pressure goes up.
Yeah, and you take meds, they go back down if you control your blood pressure.
Sounds like a stroke going to happen, right?
His heart rate only dropped to 40, but he's good. He's good. So thought to be caused by changes in blood vessel size in the base of the brain, which is causing these migraines. With that, they're experienced by both adults and children. Pain is usually described as a pounding, throbbing, or pulsating. Usually the migraines are happening through here. Sometimes it's more secluded one to the other, but again, it could be both sides. Often associated with nausea and vomiting, and may be preceded by visual changes. So you still want to ask the question, do you have any nausea? How does your stomach feel? They tell you yes, and you can call for ALS for this, but a lot of times you can just transfer them for the migraine. COVID is anything. That's all I'm going to say now. I just transported a 911 patient the other day, and they got died. They had COVID when they got to the hospital. They checked it and had COVID.
No, I know what you mean.
You know, and right. I've had patients that I transported in that had no symptoms at all, and they just do a rapid COVID and came back positive. I'm like, all right, cool. So again, COVID, I cannot give you signs or symptoms because it's everything. It's everything.
But no, I just with the migraine. I thought I heard people say something about.
A great medication though for this right here for and this would be good for migraine pain is IV Tylenol. Works phenomenal. Drip it over 10 to 15 minutes, and it works great. It's a phenomenal medication for pain, non-narcotic. What was that? Right, when your ALS shows up. So again, IV Tylenol can work really well for that. Do a gram of Tylenol over 20 minutes, 15, 20. This can last for several hours or days with migraines. I've seen it like put people down, just down and out. Yep. Sinus headaches are caused by a pressure that if you leave a result of fluid accumulation in the sinus cavities. If you have sinus cavities, you'll start picking up more of a headache. You'll start feeling your face hurts and your head feeling you. Pre-hospital emergency care, not required for this, but a lot of times they'll call because they want pain meds. Help me with the pain. There's nothing we're going to do for these sinus headaches. Take some Tylenol, go get some rest. If you need to get on antibiotics, then just go to urgent care, things like that. They probably won't give you anything anyway, so sinus headache usually goes away.
All right, how do you know?
I'm saying if it is a sinus headache. But again, if you don't know, transport. Patients may also have cold-like symptoms, nasal congestion, cough, and a fever. But nowadays, remember these slides are made pre-COVID. Oh, this could be a COVID symptom. So make sure you wear N95 masks when you go into these houses. You just don't know anymore. You just don't. It's scary stuff. Serious conditions that include headaches as a symptom are hemorrhagic stroke, brain tumors, and meningitis. So we got to do some testing for this as well. So be concerned if a patient complains of a sudden onset severe headache or a sudden headache that has associated symptoms. We'll get more into this here in a second. Suspect stroke in patients with severe headache, seizures, altered mental status, and increasing ICP also may be a cause of a hemorrhagic stroke, tumor, or recent head trauma. So when we're doing our assessments for hemorrhagic stroke, you want to ask them about the headache thing I mentioned earlier. Where does your head hurt, right? We look at meningitis, and Chris is kind of hinting over here. It's called the chin to chest. There's a name for that. I can't remember the name of what it's actually called, but you have you touch your chin to your chest. I tried to do that to a patient the other day. And then I said, touch your chin to your chest. And she was doing this with her hand. I'm like, I just want to do this, and she's like, oh, the back of my neck really does hurt. It gives me more of a headache. I'm like, I got my N95 on. Intracranial pressure. All right. And then other increased intracranial pressures. We'll get into that in a moment, how to actually check for that, for increased ICP. Unless anybody remembers what that is from reading your books. What are the indications for measuring, not measuring, I shouldn't say measuring, it's a bad thing, to tell if someone has increased intracranial pressure in the head, in the brain? It would have been in your textbook readings. Nope. It's called Cushing's triad. Chris knows. He's like, yeah. There is. You'll see things like that. Okay. So, yeah, bradycardia, irregular respiratory pattern, and blood pressure would be hypertensive.
I thought you were actually going with the narrow pulse pressure too.
Yeah, that's more towards Beck's. Yeah. But it could be, though. You could have narrowing pulse pressures, but hypertension, bradycardia, irregular respirations. 3 things. If you have those 3 indicators, and there's a potential for having increased intracranial pressure. And if I remember from my reading correctly, it's higher than 10. Correct. Yep. So those 3 things. So bradycardia, irregular respirations, hypertension.
I've seen that so many times.
Yep. I've had a couple in the field that I picked up on. And it's not. I don't see it for me. I haven't seen a ton of it in the field. I've seen it more during my clinical rotation. I saw that a lot working in the trauma centers, but not so much in the field. I've had a couple that I've actually picked up on that.
So it happens when you work Saturdays.
Unless you work Saturdays, you get one a shift. But
Is there a number that qualifies as hypertension?
so depending on textbook readings, they say that normal blood pressure is 110/70, 120/80. It depends on what book you read. 120/70, there's your range. I'm going to go with 130 systolic. They consider that pre-hypertensive. When you start getting the 140s, 150s, okay, now our hypertension is kicking in. But really, the number we're looking for is your diastolic pressure, and that's your most important one when it comes to looking at real bad hypertension. Because what is your systolic blood pressure? Systolic. Okay, but what is your systolic blood pressure? Not resting. Squeezing, right? Pressure in the arteries, right? Okay, and your diastolic is at rest, right? So if your blood pressure is 200/80, is that really concerning? What do you think? Okay, it's something to think about, but I'm not like, oh my God, this is horrible. We're going to stroke out. Now, if I told you the blood pressure is 200/140, now we're starting to think this is bad. This is something that needs to be corrected because that diastolic pressure is so high that the arteries really aren't getting any rest. There's so much pressure built in with those. There it is. Right? So that's the blood pressure ranges we're looking for. Increased intracranial pressure is not good for the brain because now there's pressure being pushed on, right? So that can cause a lot of different things from the bradycardia, respiratory pattern, hypertension, looking for that, but altered mental status, it could be unconscious. So the one I had was the last one I had was actually at Stewart's when I was there. I had a guy that had a hemorrhagic stroke, collapsed, and as he was coming down, he smacked his head off the file cabinet, had a skull fracture. But luck, right? So he ended up getting intubated and transferred out. They actually, I think, remember correctly, flew him from Huggins. This was a while ago when I was working there. But I picked up on it. I called it in. This guy said, "This guy's got Cushing's." They were like, Cushing syndrome? Nope. Cushing's triad. Remember, there is a difference from Cushing's syndrome and Cushing's triad. Completely different, by the way.
Is Cushing's hyper or hypo?
It's hyper with it has increased cortisol,
Oh, yeah.
which you'll end up getting the moon face
Oh, yeah.
as well. That would be your Cushing's syndrome versus Cushing's triad, which has to do with the brain itself. Stroke, also called the cerebral vascular accident, CVA, which is an interruption of the blood flow to an area within the brain. We cannot diagnose that in the field as far as where it is located. We can have ideas depending on assessments, and then if there's plenty of headaches and whatnot, maybe it could be here. We look for what to affect. That's more of the paramedic level stuff. But we look at the Cincinnati Stroke Scale, which would be coordinator drift, so arms out, palms up, have them close their eyes. And we'll see if you start seeing this and one's starting to fall down, okay, we know that there's an affected side, one of the indicators. The other one is facial droop. Smile for me. A lot of the times they'll like say, what do you want me to smile? Just smile, you know. You give me a big smile. And if you see one side coming down, the other one will be the slurred speech. You can't teach an old dog new tricks. Remember, that works all the facial muscles, and we're hoping to get that same word back out. But if it comes out garbled, or if they start saying the purple dinosaur on the tree in the back of the ambulance, yeah, that's not right. Right. So that's what we're looking for, to see if they can actually have the correct wording coming out in, or if it's garbled coming out. So we look for that kind of stuff with a stroke. The other thing that they utilize, and I can't remember everything off the top of my head because there's so many different ones that are out there, is something called the FAST ED. And the FAST ED scale, New Hampshire's using it, Mass is using it, and I'm going to call them Maine in like 2 years. But last I knew, Maine was going to that as well, is a FAST ED score. So they recommend, in Massachusetts, they actually tell you in the protocol, you need to download the app. There's an app for that, and it's called Join Triage, and it looks like this.
The pitch about the D is denial. A lot of people So we have stroke symptoms and they're complete
So-
denial about it.
So you can go right down through, and I'll read these out. So is the patient on anticoagulant blood thinners? Yes or no? I'm gonna click yes. Was the last seen normal? What time was the last seen normal? So if you don't know, put unknown and put down the hours here. I'm gonna put down unknown. Does the patient have any facial weakness? I'm gonna put abnormal. Does the patient have any arm weakness? Severe. Check speech content and ask the patient to name 3 common items. Doesn't matter what they are, make sure they're common. Okay, I'm gonna put down abnormal. Ask the patient to show me 2 fingers. Have them do this. Abnormal. Does the patient have a gaze deviation to either side? So the eyes, are they kind of deviated to one side or the other? I'm going to put down they have a forced deviation. So what I just got here is a number. And it says score 7, critical. Large vessel occlusion probability, 60 to 85%. And it says take it to the nearest stroke center. So when I call in, I'm going to say they got a fast CD score of 7. Join triage. All right. So this is what the hospitals are looking for now, especially in Massachusetts, but New Hampshire is also looking for these numbers when you call in. Now,
It's probably ain't gonna know.
they're not going to know about
If you go
this.
Sportsman or Maine Medical Center,
Right, the big
you
stroke
better
centers.
have your fast TV score.
Exactly. So when you're looking at the local hospitals, you're going to say stroke scale positive based on Cincinnati stroke scale. We'll know, yeah, positive evidence of a stroke. And then when they get there, the doctor will take a quick look and you're going to CT either way. Right? When they come in, the hospital staff doesn't use joint triage. They don't use Cincinnati stroke scale. They use something called the NIH scale, which is a lot longer. It's a longer series of questioning and pictograms. And if you really want to look at that kind of stuff, I downloaded the Neuro Toolkit. It's NIHSS on here. And then it goes right down through all the questioning for the NIH score. And then it also has the aphasia pictures on here. So you hold this up about 4 feet away and you have them identify what's on the screen. And then they also have the word association. Then they have a picture like this. This is the same picture they use on all the NIH scores. You have them point out what is wrong in that picture. They should be able to differentiate the difference. Okay? They look at the pictures that are there. That's all part of your NIH score. So that's another thing you can utilize. So with CVAs, obviously it's an interruption of blood flow to an area within the brain, which results in a loss of brain function. Lacking oxygen, brain cells stop functioning and begin to die within minutes. Right? This is why it's so important to get that last known well time, get them to a hospital that has CT. Now, if Huggins says to you, we put out a page or something, they say the CT is down, we don't want to take stroke patients there. That's bad because they're just going to ship them right out, and it takes longer to make that happen. Okay, so if CT is down, go to the closest place that has a CT. Okay, whether that be Memorial or Frisbee or whatever from around here, but find your local hospital that has CT available. Okay. Once the brain cells die, not much can be done at that point. So we want to make sure we limit that from happening by getting them to a center that can take care of this. Again, CTs, neuroconsults, and everything else can lead to TPA administration, right? So that's the goal if it meets the required time frame and everything else. That's why it's so important to get that last known well time, because that's going to be key on TPA administration as well as the CT to prove it's not hemorrhagic. That'd be really bad if they gave it to a hemorrhagic. Did you? Did you get to see the scan at all?
I think Laurel
Yeah. So there can be hemorrhagic strokes that have small bleeds, or to the point where there's so much blood on one side that this hemisphere kind of it shifts. The midline, which is here, will actually start shifting over. At that point, I mean, these patients usually get intubated, and a lot of times they don't even make it through those kind of midline shifts. But yeah, they do. Absolutely. Get out the DeWalt and drill away. So with stroke, obviously brain cells develop ischemia. Ischemia being what? What is ischemia again? Keep thinking. Yeah, an oxygen, right? So they become ischemic, right? Causing them to stop functioning properly. So again, this may take several hours or more for the cell death to occur, which is why the last seen normal time is so important. With prompt restoration of blood flow, the cells will not die and the function can be preserved or restored. So TPA helps with that as long as within the time frame. And TPA is a very dangerous medication. It can actually cause a lot more issues, including bleeds. All right. So again, one of the things they look for is, well, the doctors have to tell them the risk versus benefit, and they tell them here are the risks of TPA, here are the benefits from this. There's a percentage of chance that you could die from receiving this medication. Are you willing to accept the risk? They actually have to sign a piece of paper saying that they'll get TPA. All right, the family has to make a decision. They give them time. It's one of those things where they say, we need to know right now. Okay, what they need to have a little bit of time to discuss it, because this could be a life-altering thing up to the point of death. Or they could have a full recovery and live from this. Okay, so they try to make that determination usually within like 10 to 15 minutes with a discussion with the family, find out what they want to do.
All the strokes, all these issues are absolutely basically
More confusion, whether it's an
Right.
infusion or blood clot, or the bleeding into that whole area stop oxygen in blood.
Right. But they're treated completely different. You know, both of them may end up having a surgical outcome, retrieving clots, but one's a bleed where, like Chris mentioned earlier, a hole drilled to relieve the blood, or they monitor it to see if it gets better or worse. But I'm not a neurologist. I don't know exactly what they do up there for that, or they're going to retrieve the clot, or it breaks up with TPA.
Sometimes the bleeds are bad. Blood, blood. It's not really
Right. So it all depends on the size of the bleed, the location of the bleed, depending on which layer it's bleeding from. Right. So there are two main types of stroke: ischemic and hemorrhagic. Again, both stroke, but completely different types of strokes, and how we're going to handle that. The most common, accounting for more than 80% of strokes, is your ischemic stroke. That's the occlusion part. So this results from a thrombus or thrombosis or an embolus that breaks off somewhere and goes into the brain to the smaller vessels. And that could be caused from atrial fibrillation, can cause strokes, because remember, with AFib, is the heart pumping effectively, right? It's not beating normal beat, right? AFib is, so it's irregular, right? So when something's beating irregular, is your heart pumping effectively? Or as you were saying, no, right? No. That's why you find the patients that have AFib, okay, are usually on blood thinners, usually, okay? Because what's happening is there's always going to potentially be a pool of blood somewhere that's holding up that could potentially clot. And that clotting gets out, it can get into the brain. And remember, our vessels are, it might pass through all these vessels through here, but the brain vessels are a lot smaller. So when that clot finally meets resistance, it stops. And that's where you start getting the stroke. Okay. And that's where it's dangerous. So that's why people that have AFib, if they're showing stroke-like symptoms, you want to get that questioning. Are you on blood thinners? Are you not taking your blood thinners? Did you stop taking your blood thinners? Did your doctor tell you to stop? And things like that. So symptoms may range from nothing at all to complete paralysis. Depending on where it's located in the brain, can cause complete paralysis of one side of the body. You just don't know what the effectiveness of what the stroke is actually going on. You just don't know the answer to that. Which is why we could have complete paralysis, or we could have good leg movement, but again, no arm movement on the right or left side, or grips. It could be as simple as they can do this and nothing moves, but it might be a slight difference just in grip alone. That's it. Okay, so looking at the slight difference in even in grips could actually mean there's actually an occlusion somewhere in the brain. Okay. So on the picture here.
He's going to explain the difference about something to me.
Okay. So if you look at the pictures here, you can see where the clot is. We started having plaque, which forms inside the blood vessels that may obstruct blood flow. What you're having is plaque builds up, or a clot comes through the major arteries that come up through the brain, meet a point of resistance or buildup, and it stops blood flow to the rest of the vessels that are here. And this is where you start getting your ischemic stroke. So even if the blockage in the carotid artery is not complete, smaller pieces of the clot may embolize deep into the brain, becoming lodged in smaller branches, like I mentioned before, blood vessels blocking the blood flow that is actually there. So that's what we're looking to pick up on based on our assessment of doing our Cincinnati stroke scale. Oop. So hemorrhagic stroke accounts for 13% of strokes. With this results of bleeding inside the brain. Cerebral hemorrhages are often fatal, right? So this stuff can actually kill people quickly. Most of the time when I've seen hemorrhagic strokes, usually I found them on the ground, unresponsive, irregular respirations, things like that. Most of the ones I've had have been in ostomy corner. Nope, no trauma at all. They just pop a vessel and down they went. So people at high risk are those who are experiencing stress or exertion. So high risk or potential for blood vessel breakage like this would be patients that are under a lot of stress. Like let's say they just got divorced or financially in trouble, to abusive relationships, to whatever it may be. To put people under a lot of stress, right? That can cause hemorrhagic strokes because your blood pressure is starting to build up. You're getting anxious. And then pop goes a vessel. Other things would be trauma as well, head injuries, head trauma, things like that. And people are at high risk for those who have high blood pressure as well. So we got to look for all those different factors. He's not kidding. So when you look at this picture here, this is an aneurysm, so you can kind of see where the blood is down here. We had a burst vessel causing an aneurysm here and swelling. The swelling and enlargement of the wall of the artery resulting in a defect or weakening of the artery wall. So the aneurysm that starts weakening the walls of the arteries can actually burst, causing this blood flow into the brain. Again, nothing that we're ever going to pick up on in the field as far as looking at it, but we're going to be able to see the signs and symptoms of the stroke itself. So symptoms may be a sudden onset of severe headaches, which you mentioned before. They have the worst headache of their life, feel like an impending doom. I'm going to die. You're good, Oscar. Probably got these down, right?
No, I don't.
No. Just wait. Keep wondering. When a hemorrhagic stroke occurs in an otherwise healthy young person, it's likely caused by a buried aneurysm. So surgical repair may be possible if care is sought immediately. So we got to get them to the hospital.
Year-old child
Who's that?
caught up in a chain
Who's
of
that?
laceration. Repeating for
Who's the medical
unfortunate
center?
accident.
Oh, Ron. Sunday, right?
For a 0-2-year-old that was caught in a chain that now has a laceration. 11-02 is first.
Pediatric patient.
Okay, I got it.
Patient assessment, let's go.
Year-old bleeding. All right. So glad this is going to be one hell of a recorded session. All right. So TIAs are a transient ischemic attack. These are more of your mini strokes that last an hour, 20 minutes, and then all symptoms get resolved. So a patient may exhibit signs of a stroke, and they'll have everything that looks like an occlusive type of stroke. The arm drift, facial droop, slurred speech, and everything. So when a stroke-like symptoms go away on their own, in less than 24 hours, the event is called a TIA. So again, so no actual death or tissue occurs with TIAs because it hasn't been long enough. Okay, because it's a mini strokes there, then it's gone. you got to be able to pick up on that kind of stuff during your assessment. How long has it been going on for?
He doesn't comment on that.
No. All right. So symptoms of TIA can last up to 24 hours. Again, may not be able to differentiate between the stroke and a TIA because you can't really differentiate the difference until those symptoms dissipate. Every TIA is definitely an emergency because that TIA that's going on can actually turn into an actual stroke. This may be a warning sign that a more significant stroke may occur in the future. So again, transport them to the hospital, encourage them to go. Because if you sign them off and they don't want to go to the hospital because say your symptoms resolve after like 30 minutes, and then it happens again while they're sleeping at night, they've lost all chances. At least let them go to the hospital, get a head CT done, confirm there is no bleed, talk with the neurologist, have that discussion. At least that process is being started.
All their work was
They're not going to show the occlusion, but they may schedule them for an MRI that will. So, and all patients with TIA should be evaluated by a physician. So try to convince them to go to the hospital. These are not ones you want to say, yeah, you don't need to go. Actually convince them to go in and get evaluated. Signs and symptoms of a stroke will be your facial droop, so one side or the other. Sudden weakness or numbness in the face, arm, leg, or one side of the body, so the drifting or weakness in the legs. So again, like you do with a
02-year-old that was caught in a chain of laceration.
Right. So again, they may have weakness. So if you know, we check CSMs, right? Upper and lower, we do trauma assessments. It's the same thing here. Check for pushing down, pulling up, check for sensory functions in the legs as well as the upper body. Lack of muscle coordination or ataxia or loss of balance as well. So when they're sitting there and they have that lean like this, they're not able to control their trunk. So if you see that lean over, that might be an indication of a stroke as well. So pick up on those. Unable to have muscle coordination. Right. Sudden vision loss in one eye. That can happen with strokes as well. Because you can also have occlusions in the back of the ocular occlusions as well with those, for the arteries behind the eye. Blurred or double vision, difficulty swallowing, decreased level of responsiveness, and speech disorders. So again, what else can mimic a stroke? Bell's palsy. What else can also show signs of altered mental status? Sugar. Hypoglycemia. They gave me eye drops.
Oh. Oh.
That was horrible. So again, if they have difficulty swallowing and their blood sugar is low, we got to be very careful with giving them oral glucose so they can choke on it and they can't maintain their own airway. Right? Right? Pretty quickly. And yeah. So that's more of what they call a buccal administration. So you use it on a tongue depressor, or just don't stick it in their mouth and squeeze it. All right, slingshot in the back of the throat with the sugar cubes. No. You want to take it, put it in the sides of the gums. So let it buccally dissolve in. That's what's supposed to happen. But most of the time people just take the packet and go squirt it in their mouth. That's not the way it works. It's supposed to be a buccal administration. You okay? So aphasia is difficulty expressing thoughts or the inability to use the right words. Remember I mentioned aphasia earlier. They have a hard time getting those words out. Okay, that's the aphasia part. You want to be able to pick up on aphasia. So difficulty understanding spoken words or called receptive aphasia. So if I say, you can't teach an old dog new tricks and it comes back as ponies fell bloody on the ground, what does that even mean? So they have a hard time getting these words out. It's complete disassociation. Or they'll say, They just have a time getting stuff out of their mouth. If you see this kind of stuff, again, note this. That's all part of a patient having a stroke. Slurred speech, dysarthria, sudden or severe headaches, confusion, dizziness. Other ones would be weakness, combative restlessness, tongue deviation, or coma. So anytime we do in a stroke assessment, we have to stick out their tongue like this and back in because we want to make sure they can stick their tongue out. We also check accessory muscle use as well. We have them shrugging their shoulders. It's all part of the cranial nerve checks also. We do this. Can you feel this? Can you feel this? I do it again. Does this feel the same as this? And they'll say this side feels different than this side does. All right. So now we know we have some sensory issues as well. We check pupil reactivity. What size are they? Are they both reactive or is one pinpoint and one dilated? Now, people can live like that also, or that are born that way that have unequal pupils. I'm drawing a blank of the name, what that's called. There's a name for it. I'll think of it in a little bit, I'm sure. So the left hemisphere, strokes in the left cerebral hemisphere may cause aphasia. All right, so the inability to produce or understand speech. So speech problems can vary widely on this type of an assessment, right? Stroke may also cause paralysis of the right side of the body. So left hemisphere controls right side of movement. The right hemisphere strokes may cause paralysis of the left side of the body, but usually patients can understand language and are able to speak. Words may be slurred. So do you see the difference between the two? We'll go back a slide. Right? Inability to produce or understand speech. Speech problems can vary widely from the left to the right, where words may be slurred, but they can understand that language. So if you see that, okay, they have a hard time getting the words out, it's a left hemisphere issue, right? But if they understand it and the words are slurred, it could be potential for a right hemisphere. That's going to help you with your assessments. So, all right. Patients may be oblivious to their problem or neglect. So remember how Chris had mentioned earlier about the denial for the fast CD stuff? They don't believe it's actually happening. Neglect and lack of pain cause many patients to delay seeking help. That's why when you get there, oh, it's been going on now for 24 hours. There's not much a neurologist can do after 24 hours of this. A lot of times it might just be comfort care from there on out. That's why it's so important to get recognition of those strokes right away and get that last known well time. I know I mentioned that like 30 times, but I can't express that enough. How important that is. I don't know. It just kind of gives you an idea where it's located. Hey. Gabriella. Go drink that somewhere. Have some more sugar. Take it with you. Okay. I tried. Get some more sugar in you. So bleeding in the brain. So patients may have high blood pressure. Could be a cause of the bleeding, also be caused by bleeding as a compensatory response. Increasing blood pressure is an important sign. So again, when we're checking stroke patients, blood pressures are very important. You get every 5 minutes to see if you're seeing a blood pressure climb, but also get them on both arms, okay? Because you may have one blood pressure that's elevated on one side and the other side could be low. There could be a difference between the two. So check both sides. So increasing blood pressure is also an important sign to pick up, and significant drops in blood pressure may occur as patients' conditions worsen. So you'll see the hypertension, and then they may bottom right out. Okay. So monitor blood pressure changes, but also monitor blood pressures in both arms. But in your narratives, when you're documenting this, though, you want to make sure you document blood pressure right arm, blood pressure left arm. So hypoglycemia, obviously not enough blood glucose, which we already talked about. Postictal state following seizures will last between 5 minutes to 30 minutes. These are conditions that may mimic the strokes. So if they've had a seizure history, or let's say they fell and smacked their head and they have a impact seizure from a trauma. We want to note what kind of seizure was it. Was it an absent seizure where they were just staring? Was it a tonic-clonic seizure where they were shaking like a fish flopping like a fish on the ground? What kind of seizure were they having? And then how long did the seizure last for? And then on top of that, note their postictal state. Be careful, please. Okay. Subdural or epidural bleeding, which is blood near the skull that presses on the brain itself. So you have an epidural, or we have a subdural, or an subarachnoid bleed, which is up here in the different spaces. That's causing pressure. Remember, if the skull's not cracked, we can't bend that skull, right? It doesn't move. So if we have a bleed underneath the skull in that epidural or subdural layer, where's that pressure going to go? Into the brain, right? So it's going to push on that, causing an effect like a stroke. Okay, and that might be as simple as letting it heal itself, or if it's really bad, drilling the brain and removing that blood. So as you can see here, see the subdural hematoma in the corner there? Right here? So the skull doesn't move. This is the dura here. What's happening is the subdural hematoma, so below the skull, is pushing on the brain itself, right? And the angry pumpkin face here gets more angry. All right. Now, if we have a fracture, okay, again, unless it's really crushed here, but it's just like a fracture line that's here, this will cause the bleed, but not allow for it to be pushing outward, but inward. Subdural hematoma is over here, as you can see, as well. So that fracture causing the vessel to break, and then pushing against the brain, causing the hemorrhagic stroke type deal, or the stroke from the bleed. All right. Any questions on strokes at all? No, Gabrielle, you good? All right. Can you flop like a fish? No, not on the ground. Don't get on the ground. Lay on a blanket, then you can flop like a fish all day. Right, now he's gonna get penetrated.
It might stink now. It's on his back.
Gabriella. Or that works too. All right. So seizures are a neurologic episode caused by a surge of electrical activity in the brain. So a big surge comes in, causing you to have a seizure, right? Now, this can take the form of convulsion and/or can be associated with a temporary alteration in consciousness. And then there are two basic groups. We talked about generalized and partial, which are more focal seizures. Let's get more into those. Generalized seizures result from an abnormal electrical discharge from large areas of the brain, typically characterized by unconsciousness and generalized severe twitching of all muscles lasting several minutes or longer. May simply be characterized as a brief lapse of consciousness and does not involve any changes in motor activity. So now that I read you the whole slide, let me go a little more in depth on this. We have the electrical discharges from the brain, right, coming in. By doing so, it disrupts brain activity, causing us to start shaking. But again, you could have that focal or partial, where you may have just a twitch of the arm. It could be just movement of the eyes going back and forth, or it could be just a blank stare, where I just stare at you like this, right? And there's like, it could be having a seizure as well, right? This, yes, yep. And we have patients that do that a lot. And some of them are pretty convincing that we actually treat. So, and to kind of bring up pseudo seizures, I had a guy that was having them, but again, he told me he had a history of seizures, knew when they were coming on. Now, I ended up giving this guy 30 milligrams of Versed. Now, normally they'd be unconscious by that point, right? Not at all. By the time I hit 30 milligrams of Versed and he still wasn't unconscious or that sedated, one of the things I was thinking about that time is he a user of benzos and he has a high tolerance? which that was the case. Now, I'd never met the kid before in my life. You know, the guy was 22 years old. Brought him to Lakes Region Hospital. That's where he wanted to go, and had a seizure on me, and I ended up giving him 30 Versed total. And again, never went unresponsive at all with me. Pseudo fake.
There, yeah. So I had.
Or the brain.
This guy was.
I don't want to say fake. They trick their brain into having a seizure somehow,
Yeah.
and even though it's not.
So he said that the lights on the cruiser.
Yeah.
And it was. He would just automatically just start flopping on the ground. Literally.
But you have to call because you don't know.
Right.
Yeah.
And
Yep.
just treat him like he's having a seizure, and I'm like, oh, I'm gonna arrest you eventually, buddy.
I mean, you just got yourself 2 more hours out of jail. So I mean,
Yeah. So I arrested him
enjoy your last meal.
on a warrant, and he ended up. I'm like, so I know you have to do seizures. Oh yeah. I said, all right. Well, I explained like the whole process. And didn't have a seizure.
Yep.
Like, oh, okay.
So we still got to treat him either way.
It's annoying, but,
Yep. We have a kid that we go to all the time in town, but truly has a neurological issue seen over at neuro centers, but he'll seize for 30 minutes.
wow.
We get there, give him medications. It takes a while for him to break. You need to go use your. Yep. That's also a possibility if they have that implanted. Yes.
What's that?
So when they have a device underneath their skin, and if they take a magnet and wipe it over it, it's supposed to stimulate to stop the seizures.
He went into one day and
Right. All right. Partial seizures. All right. So partial seizure or simple partial seizures. There's no change in the patient's level of consciousness. May have numbness, weakness, dizziness, visual changes, or unusual smells and tastes. Probably COVID, right? May have some twitching or brief paralysis. So again, these are your partial or more your focal seizures that we're talking about. Your partial seizure, complex partial seizures, you'll have the altered mental status, results from abnormal discharges from the temporal lobe of the brain, where you start seeing that lip smacking, eye blinking, and isolated jerking. So you just see you might pick up on just the isolated jerking of the leg, just doing this. The lip smacking, like that. Unpleasant smells. They might have some visual hallucinations or uncontrollable fear or repetitive physical behavior. So it's something to pick up on when a patient's having partial seizures. So I had a call that was very similar to this. So the guy had all of these, but was very aggressive, involved in a motor vehicle accident. His girlfriend was a nurse who was on the phone with us. And this guy, I mean, I gave him 10 Versed, didn't touch him, and he's being very combative. We didn't know it was seizures at the time. His call was going to be combative. We had 4 cops on him from Ossipee. 4 cops taking this guy. He was fighting him, throwing him right off him like it was nothing. He was having seizures. Yep. So I ended up giving the guy 400 of ketamine. And I knocked him right out. He was out cold. Still breathing on his own. We kind of ventilated a couple times for him, but it stopped everything that was going on. Now, keep in mind, he was probably still seizing, but I sedated the hell out of him because he needed to be sedated to get him to the hospital. This guy was pretty built. So it took me and the 4 other police officers to really hold him down. And I had him pinned, and I had someone take over for me so I could give him the ketamine. And once the ketamine got in, I could do whatever I wanted with his arms. He wasn't fighting me at all. He was completely unconscious, completely sedated. That's what it took, was 10 Versed and 400 of ketamine to take this guy down. And he was having complex partial seizures. So obviously he didn't get arrested for, punching 4 cops and taking him down because he was having a seizure. He didn't know. Apparently this guy is actually a pretty decent guy, So again, you never know what you're coming in contact with. And if they have history, you got to just keep that kind of stuff in mind. Motor vehicle accident. Not all motor vehicle crashes are because of trauma. It could have been a medical condition that caused it. The aura, is what patients experience prior to having a seizure. They get that feeling that they know it's going to happen. So that kid that had the pseudo seizures I was telling you about, he knew exactly what to do and continue on with this. But how someone can do that and trick themselves into having a seizure like that and have those symptoms continuously for 15 minutes, faking a seizure for 15 minutes, doing this, that takes a lot. Your brain has to be tricked into having a seizure. So, yeah, 15 minutes this guy did it for. He timed it after giving him Versed, and he didn't get knocked down. So again, why is he not unconscious? Is now he's building up a tolerance, and so is he a user of benzos? Question to ask, So patients may experience this prior to, it's called an aura. They know, a lot of times patients that have seizures, that have auras, will actually lay themselves onto the ground saying, I'm going to have a seizure, call 911. And they'll lay down, and then they'll start seizing. They know it's going to happen. People with a history of seizures recognize the auras, usually take the steps to minimize injury. That's sitting, laying down on the ground. Auras do not occur prior to every seizure, and not all patients with seizure disorders experience this from actually happening. But again, if you're in the back of the ambulance transporting a patient with seizure history and they tell you, I'm going to have a seizure, they're probably going to have a seizure because they know it's coming. So generalized seizures, obviously characterized by sudden loss of consciousness, chaotic muscle movement, and tone and apnea. They may exhibit bilateral muscle movements characterized by a cycle of muscle rigidity, relaxation, usually lasting between 1 to 3 minutes of this. You also see tachycardia, hyperventilation, so tachypnea, sweating or intense salivation, so a lot of drool coming out. Most seizures last 3 to 5 minutes in the postictal state, about 5 to 20 minutes that follows after, and a gradual return to consciousness. So it may take some time. Now, you may have patients that have seizures that just don't want to go to the hospital, okay? Or family will say, I don't want him transported. I want him leave staying here because he has them all the time. So a lot of times they'll wait and wait until they become more responsive, check a blood sugar because, again, it's altered mental status. You don't know if it's a sugar issue that caused it. And a lot of times they'll end up contacting med control and just do a patient refusal. Please stop. All right. But again, if they've been seizing and they have history of seizures, the family may actually have medication like diazepam or Diastat that they give them. All right. And once they've hit a certain dosing regimen, and let's say they give them like 20 milligrams of Diastat and the seizures still aren't breaking, then they'll call 911 and have EMS come in to give something a little bit stronger or a different type of benzo. Because normally they'll seize and they'll stop and they'll let them sit in bed because, well, it's common for them. They may seize, 30 times a day. And if you go to like head trauma facilities, case in point, for those of you who've been in the Valley for a while, before Green Mountain was Green Mountain, it was a neuro rehab center, right? You guys remember that at all? Anybody? Yeah. So 244 High Watch Road, it used to be I think it was Lakeview Neuro Rehab before it became the rehab center. And we used to go there for seizures a lot over there because those are ones that maybe have had potentially 20 seizures that day. And then they call back because they just kept going. So an absent seizure, which is formerly called the petit mal seizures, with these, they may last for a couple seconds and then they go away. So patient fully recovers after a brief lapse of memory, and then they're back to being normal again. So what they used to call petit mal, back when I took my EMT class, it was called that, but now they're just calling them absent seizures. They kind of changed the name of it. So status epilepticus, this is the dangerous one, okay? So seizures lasting more than 5 minutes are likely to progress to status epilepticus. So seizures that continue every few minutes without the person regaining consciousness or lasting longer than 30 minutes are referred to as status epilepticus. These are patients that have recurring seizures that just don't stop. These patients need to be treated quickly. They need sedatives. They got to find a way to break those seizures. And again, we may give as many medications even at the ALS level, and it may not even stop these. Okay. So a lot of times these patients will end up getting RSI intubated, even though they're intubated, and they're sedated and paralyzed, they're still having seizures. It doesn't stop. So they have to go to a neuro center that can help with that.
Like they're having mentally, or
Yeah.
their body's still blocking.
Well, if you paralyze them, the thing is, we give like a longer paralytic. Not that you guys need to know all the names, but like, let's say rocuronium, a longer paralytic, that's there, lasts 45 minutes. And then they get heavy sedation to knock people out. Their brain still may be seizing
Oh, but their body.
or just out.
And you're like, how do you transport
Right.
that?
So a lot of times what they'll do is they'll put them on what they call an EEG, which is done more at the neuro centers. They actually measure that brain activity that's going on. So some causes of some seizure disorders are congenital, like epilepsy being one of them. So your cruiser that you were talking about, Kim, about the lights flashing. If you have patients that have epilepsy history, turn your lights off because that can trigger epilepsy. So we show up, lights and sirens and everything else, looking cool going down the road. Next thing you know, you start triggering seizures of this person you're going to their house for. So when you get close enough, shut everything down. Another thing too to shut down for lights, patients are having acid trips. Don't turn lights on for them. They don't like that much. We found that out in Wolfboro because Brewster Academy had about.
Hey, rich kids do drugs.
They don't.
There's a guy like that over in Stanford.
This conference will now be recorded.
So tell me about high school again.
Yeah.
All right. All right. So this has been an interesting day. Epileptic seizures usually can be controlled by medication. These are all the different medications that are listed behind me on the screen as long as it's still working. So we have phenobarbital, phenytoin, Keppra, Tegretol, Depakote, Topamax, Klonopin. But again, all these medications that are there, we do not carry pre-hospitally. These are all things that they are usually going to be on long term. So when you're asking, are you compliant with your medications? They may tell you, no, I can't afford it. No, I don't take them. Or yes, I am. And now if they're compliant with their meds and they're still having seizures, that's a problem. Why is the medication not working? Do they build up that tolerance? These things have to be adjusted. So seizures may also be caused by an abnormal area in the brain or structural cause, such as a benign or cancerous tumor. So putting pressure on the brain or causing that electrical activity to happen. Or an infection like meningitis. So we talked about meningitis. They'll usually occur with fever, okay? And then severe neck pain going into the head pain. So that's why we have them do the chin and chest thing, because if they do that with high fever, again, pain from the lower part of the back shooting right up the neck into the head, right, going to the meninges in the back, causing severe inflammation. The only way to tell if someone has meningitis, though, is they're going to have to do a lumbar tap or spinal tap. They got to get that fluid out. The cerebral spinal fluid comes out, and they test that for meningitis. Okay. Scar tissue or some type of injury as well. So again, you got to ask those questions about cancer and things like that. Do you have the history of brain cancer? A lot of times they have brain cancer if it metastasizes throughout the body, or things like that. Things you want to find out is, do you have any DNR orders, any advance directives, living wills? Because we have to know that information. Okay. TBIs, yep. But we have to know this information to be able to help treat, because again, if they're having recurrent seizures over and over again because of a brain tumor and it's inoperable, if they code, what are we going to do? So a lot of times they'll be on hospice care, or they'll have DNR orders in effect to make sure you have that kind of stuff with you. Seizures from a metabolic cause can result from abnormal levels of certain blood chemicals. So again, we have to get them to the hospital so they can do your lab draws. Hypoglycemia, poisons, which you talked about, different types of trips. Trips to Disney. Nothing. All right. Drug overdoses, sudden withdrawal from routine heavy alcohol or sedative drug use, which is why we go to seizures a lot over at Green Mountain Treatment Center, or they send patients over by van to the hospital. Because again, they're withdrawing from stuff, they're going through rehab, so they're seeing a lot of those seizures. Prescribed medications or seizures can also be a result of a sudden high fever, particularly in children. So it's not the high fever that causes the seizure. What is it? You guys know? How fast it gets there. Right? Our bodies are not designed to go from 98.6 to 104 over the course of an hour. Not designed for that. Usually it increases. But that fast increase in a kid will set off a seizure because your body is trying to find a way to stop that from heating up by seizing, causing your body to cool down. Okay, so that's what your body is doing with that. So what they're trying to do is your body's mechanism is saying we need to stop this heat rise. So a lot of times you'll get called to a pediatric febrile seizure, and you get there and the kid's perfectly fine, crying, wet diaper, everything looks good. And they got a temp of like 99. Well, what was it prior to? Did they go up to 104 or 105 and then they seized and brought it back down again? That's the plan behind it. Right. It can. So they still got to find out what caused the fever, So try to convince the patient's parents to let them go to the hospital, or if they say no, can you at least bring them by personal vehicle? At least get them to an ER. Always try the route of ambulance first, but if they say absolutely not going to happen, I can't afford it, I don't have the insurance, all right, then if you can't go with us, which we recommend you do, can you at least take them by your own car to the hospital instead? That way, if something happens, you can always call 911 again, but we recommend they come with us so we can treat it right away if something does happen. So the importance of recognizing a seizure, obviously, is when a seizure is occurring and whether or not the episode differs from previous ones, differs from the previous ones that were there. So the patient may turn cyanotic, which is what? What's cyanosis? Flu. Seizures may prevent the patient from breathing normally. If you're seizing, you're not really breathing. All right? They become very hypoxic during seizures. In a patient with diabetes, the blood glucose level may also decrease. You can seize from low blood sugar. In patients with if protocols allow monitor blood glucose levels after a patient with diabetes has a seizure. Either way, if someone has a seizure, doesn't matter if they're diabetic, non-diabetic, pre-diabetic, doesn't really matter. Check a blood sugar. Sometimes, but mostly it's your decreased blood sugar, hypoglycemia. Look for other problems associated with the seizure itself. So the patients have fallen during a seizure may also have a head injury as well. So the question to ask is did they have a seizure and fall and have a head strike? Or do they fall, have a head strike, which then cause an impact seizure? That's going to be based on your history and your sample history, which is what? What's sample? You gotta be really loud. Right. So that sample history will give you all the information you need to determine which one it was. Events leading to past medical history, right? Two important things. They say, no, he doesn't have a history of seizures, but he was outside working and you see a ladder next to you. Okay. Did you fall off the ladder, strike his head, cause a seizure? So I'm going to go with trauma, C-collar, trauma assessment, and get him to the hospital. Also, another thing with patients having generalized seizures may also have experience incontinence. 90+% of the time, they're going to piss themselves. The postictal state, so after a seizure, the muscles start to relax, becoming almost flaccid, and breathing becomes labored because at this point in time, the seizure is stopped. Now they're completely just worn out. They just lay there like they're unconscious. That doesn't mean start putting in OPAs and NPAs. They're postictal. If they're not breathing appropriately, just take a BVM and help them breathe, or just put on a breather and see what happens. Give them some oxygen, right? So start shoving things in their orifices. All right. Right. With normal circulation and liver function, the patient will begin to breathe more normally within minutes. It doesn't take very long. They have to metabolize and just recuperate from that. It could take up to 30 minutes when they're postictal. So again, they may be characterized as hemiparesis as well, so it could resemble a stroke, but they should come out of it and be back to normal. Most commonly characterized by lethargy and confusion, the patient may also become combative. Also, you might find in a combative patient to be hypoglycemia. So we still need to check a blood sugar, because that low blood sugar could have caused a seizure, causing the combativeness, because the blood sugar is probably 10, when it should be between what range? Was that the range for blood glucose? Yep, for anybody. 80 to 120, 70 to 110, depending on what books you read, for that range. Right? Our bodies don't function well with a blood glucose of 10, right? And they're unconscious. We're not going to give them oral glucose. We need ALS to give them D10 for administration. If the patient's condition does not improve, then consider hypoglycemia or any type of infection. Okay, infections like meningitis, sepsis, what's causing them to become hypoglycemia, or sepsis you'll see hyperglycemia, but meningitis, anything that would cause an infection to the brain causing a seizure like that. All right, so any questions on seizures? We're getting to syncope. Syncope is an important one for us to pick up on. Good? So my goal is to finish this up here, and then we'll take lunch, come back, do the next lecture, and then do some practicals with her, or we can do a lecture on another night, just kind of move it a little bit. So it's up to you guys. We'll figure it out. Seizures are often mistake for syncope or fainting. Syncope happens quite often with a lot of people from all ages, where they pass out and regain consciousness again. But fainting typically occurs when a patient is standing. Seizures may occur in any position at all. Fainting is not associated with any postictal state. The question is what caused the syncopal episode? And we got to do some, I like to use the word interrogation work to find out what's really going on and why they had that syncopal episode. Things that could cause syncope could be chest pain, hypoxia, a sudden onset of receiving bad news can cause you to pass out. People can see at the sight of blood can cause syncope. Low blood pressure can cause syncope. They're hypotensive, so they could be lying down and they jump up. So if every one of us right now were to lie down on the floor and then or kneel down, kind of like in a catcher stance, and stand up fast, what do you feel like? You're like, whew, like that, right? If your blood pressure can't recuperate fast enough and your heart rate, then you pass out and then you wake back up because I think your body is way resetting itself. So that's a little bit different. Now you're stimulating the 10th cranial nerve, which is the vagus nerve. That's what they call the vasovagal when they bear down, which you may see syncope doing that because it causes them to bear down, dropping their heart rate. So a lot of times we'll see commode codes. You ever heard of that before? People die while taking a poop. We call them commode codes because they're coding on the commode. So what they're doing is they're constipated, especially in the elderly, where they're already on beta blockers as it is, and then they're bearing down, trying to pass that stool to the point where they actually vagal themselves out and pass out. And then because their heart rate drops, everything drops so suddenly, and they're also on medications as well, they don't come back and then they code next to the toilet.
They fall between the friggin' wall
In the toilet.
and shit.
And you can't get, right. So then we got to pick them up. We got to drag them to the living room while their heads smacking on doorways, and we start doing CPR. All right. So causes of altered mental status, we can see hypoglycemia. So again, check a blood sugar. So you may have the same things that mimic strokes and seizures, like the hemiparesis, or a patient who has had a stroke may be alert and attempting to communicate. Patient with hypoglycemia almost always has an altered level of consciousness or decreased LOC. Again, patients commonly take medications that lower the blood glucose level. So you got to look at all the different medications that are out there that help with that. So they're on like metformin or I'm not drawing a blank of some names. Right, so they're glucose medications. They could be on insulin, like Dilantin. I'm trying to think of some more now, and whatnot. So look at their medication list and kind of see what they have, and then with that, we'll help look at their history of whether or not they had an issue with hypoglycemia. A lot of times, what you'll find also when dealing with patients with hypoglycemia is that they are on insulin and they're on like a sliding scale. And what will happen is they'll take their insulin, then not eat something. So what's happening is they need that food coming in, that energy in those glucose stores to help be released to burn everything off, right? If there's nothing to burn, then our blood sugars start dropping and dropping and dropping because they're on too much insulin. And then to reverse that, we got to give them D10 to bring it back up again. And it's hard with that match. We used to see some of these come in all the time with hypoglycemic issues, and he was there 3 times a week because he couldn't get to control it. He was horrible at maintaining his own blood glucose levels. They'd always be down to like 20 because he was on insulin, never ate, or he was taking too much of it and didn't work. So we'd have to deal with that. Consider hypoglycemia in patients who have altered mental status after an injury such as a motor vehicle crash. So look at your surroundings inside the vehicle. Do you see a patient holding a candy bar as they crash the ambulance and there's a candy bar half eaten? Maybe they knew their blood sugar was getting low, they tried eating it, and they crashed their vehicle. Or if you walk into the house and you see someone on the ground next to the refrigerator, unconscious, and there's a syringe. They could have been trying to give themselves insulin. Or not insulin, but they're trying to give themselves. They're not in Sanford, right? That's usually something else. Not in Sanford. All right, delirium. Obviously, symptoms. Remember, it's a symptom, not a disease. So what this does is it presents as a new complaint of delirium. So a temporary state that may have a physical or mental cause, such as infection, hypoxia, change of medications. It may be reversed with some type of treatment. So if they're delirious, delirium is kicking in, why is it happening? So do they have a major infection? So we got to look at the body, find out if there's any kind of infection source. Are they septic? That's another thing you look for too as well for altered mental status is, are they septic? Look at blood pressure, heart rate, end tidal readings, glucose levels, respiratory rate, heart rate. All these different things all mean something within sepsis. I'm going to go over sepsis later on. But could that infection have caused complete bacteremia of the blood, causing a systemic vasodilation, causing drop in blood pressure? So anytime you have an infection like sepsis, it causes widespread vasodilation. So our blood vessels get a lot bigger. By doing that, we start having what they call bacteremia. So the bacteria gets in and it's causing a full body infection. Systemic inflammation. That will actually drop the blood pressures down. By doing so, it requires a higher oxygen demand, causing pulse oximetry to drop down, which puts them into a hypoxic state. And treatment for that's going to be more fluids and more fluids for these patients. And I'm saying fluids, 8 to 10 liters of fluid going back into these patients to help fix that vasodilation to the point where they may actually get pressors to help bring their blood pressures back up again because it's so low. So other signs and symptoms obviously would include like confusion or disorientation, disorganized thoughts, inattention, memory loss, striking changes in personality and affect, hallucinations, delusions, and decreased level of consciousness. A rapid alteration between medical states as well, and symptoms that may mimic intoxication, drug abuse, or severe psychological disorders. So again, we have to look at everything as a whole and do our assessment to find out what is actually causing this to happen. All right, is it hypoglycemia causing them to be upset or delirious? Is it sepsis? Is it an infection? What is causing? Is it drug abuse that's causing delirium? We don't know until we start doing our assessment and actually asking them the appropriate questions. Also looking at your surroundings when you walk through the door. Do we see stuff laid out across the counter space?
Oftentimes with the attendant, you don't want to, they should be going to the hospital.
Yes.
Regardless of what.
Exactly. And we can't get patient refusals on them because they're altered. So we have to take them to the hospital. Now, they may not want to go with you, so your best resource is going to be PD, right?
I had that issue. I felt.
Can you PC somebody like that or force them to go to the hospital,
Yeah, so
like in Mass?
I thought it was okay to get people that were staying with, like the supervision to watch her, make sure that she was okay, and then I was very familiar with the whole effect of delirium, and they're like, no, she is going. She could overdose and literally die with by the time she was no longer.
So we can't leave them alone. Massachusetts has what they call sections, but the section 12 is more for psych. But they have something called a section 9 or section 9A that they can actually force medical evaluation on people. And they can do that to anybody. Any one of us in the room, they can walk up and they're going to say, you need medical evaluation. You're going to the hospital. You can't get out of it. You have to go. Normally, hospitals put those patients by the glass doors in the back so they can get up and walk out. But all right, so when dealing with this kind of stuff, we want to make sure the scene is safe. So the dispatcher in some calls to the dispatcher, the description of the patient, signs and symptoms will be provided a fairly good idea of what's going on. You just got to keep in mind that the whole story sometimes isn't really painted through dispatch. Okay, a lot of things can change during the time of the call, or the caller gives people false information to get an ambulance there faster. I've had that happen a lot, where ambulances have been dispatched for chest pain and they don't have chest pain. They just want you to come take a blood pressure for them, but they figure the ambulance will get there faster, and they said chest pain over the phone. That whole abuse of 911. You guys know what that is now. Never heard of it. So a patient with altered mental status may also exhibit a wide range of signs and symptoms and behaviors. Again, without getting, one of the hardest things to do in EMS is when doing evaluations is going to be your altered mental status, because there's so many different things that can cause that we got to figure out which one is it going to be. And that's where you have to start using differential diagnosis. And if I had a whiteboard, I'd show you. I like calling it the reverse pyramid. So I draw a pyramid out like this and down. Here's all the things that potentially could be. Here's all the testing we can do. And here's a diagnosis that we're going to come up with in the field and treat. So if a patient has altered mental status, we got to do different checks, EKGs, blood glucose checks, right? Stroke assessments, history taking, vital signs. All these things indicate what we're going to come up with a treatment plan by ruling things out. So if I got an altered mental status and the blood sugar is 120, is that ruled out now? Absolutely, it's not 10. So I'm not worried about hypoglycemia or hyperglycemia, right? If we do a stroke scale on somebody and they can smile, talk, and move around, like if you go to altered mental status, they aren't running around the room, could that be a stroke? Probably not. But they're sitting there swearing at you, calling you every name they could think of. Speech isn't slurred, right? They're moving their arms like this, being all frantic. So let's worry about pronator drift, right? So it may not even be a stroke. So all you smell is alcohol, but the blood sugar is normal. Okay, we know it's not DKA, because you wouldn't have that fruity smell on your breath. I mean, you would have a fruity smell on your breath if it was DKA. So you can kind of rule that out. I'm not saying go up there and sniff a guy, but again, if you don't smell it. So again, a lot of things you have to do. When we cover more medical assessments, we'll go over that more in detail. Do not be distracted by the seriousness of the situation or frighten family members. Family members sometimes they're freaking out, and you just don't let them get in your way. Just do your job, do your assessment. Just tackle them down. Ask family when the patient was last seen normal as well. Remember, you need to get that last seen normal time. Look for life-threatening conditions. Again, as you approach the patient, gather information, note the patient's body position and level of consciousness. Initial impression, sick or not sick, right? We go in there and do an initial impression. You should be able to tell if a seizure took place. Ask questions. If they're seizing, actively seizing, call ALS, get there to stop the seizures. Use your ABFU scale, which is what? Perfect. I like it. Assess ABCs, so airway and breathing. Patients may have difficulty swallowing and choke on their own saliva. So we may need to protect their airway, suctioning. Be prepared to suction and position the patient and prevent aspiration. So if they're lying down, turn them on their left side. Whether if they vomit, it comes out, suction as needed. Don't lay them flat on their back. If they can sit up, and sit them up. That way they can vomit out or drool outward. The patient, position the patient to prevent aspiration. Check for foreign body obstructions if there is any. Remember, hypoxia can be caused by a foreign body airway obstruction. And also assess the patient's breathing. So in patients with altered mental status, regardless of the cause, should receive high flow oxygen. So give them an on breather, 10 to 15 liters per minute on their face, let them breathe. Ventilate the patient at the proper rate and proper volume if needed. Remember, 10 to 12 breaths a minute, delivered over 1 second. If we need to rescue, breathe for them if they stop. If they're hyperventilating, this may have a negative consequence. So obviously decreased cardiac output, result of regurgitation, aspiration, and further injury to the brain. With patients with intercerebral bleeding and increased intracranial pressure. What we don't want, an old school thought used to be hyperventilate these patients to help. It's actually killing them, so we've got away from that. Now we're going to just breathe normal for them. So they're hyperventilating, we got to help them breathe. The paper bag tricks, we don't use those anymore, okay? We used to use a non-rebreather mask with no oxygen in it, put them on their face so they could rebreathe their carbon dioxide that they're exhaling. We're not doing that kind of stuff anymore. They've actually said that's actually bad for them. They want us to give 100% oxygen as they're breathing rapidly, if they're semi-responsive. But then they take a breath in, just force some oxygen, just breathe, and breathe for them. Help control that hypoxic drive that they have. So yes, we're going to be ventilating patients at the EMT level that are still conscious and breathing. Circulation, obviously check the pulse if the patient is unresponsive. If there is no pulse, CPR. Again, if you feel, check for a radial. If there's no radial, where do you go next? Check for a carotid. No carotid, start CPR. If the patient is responsive, determine if the pulse is fast or slow, weak or strong. That means a lot, right? For checking for a pulse, if it's bounding versus normal, right? Bounding pulses, rapid, is it weak? And evaluate the patient quickly for any kind of external bleeding. So you do what they used to call the blood sweep. Look at it. They're bleeding out, stop the bleeding. Because that can also cause altered level of consciousness because now they're losing their oxygen in their blood, becoming hypovolemic. Then make your transport decision. Establish your priorities based on the assessment of the patient's level of consciousness and ABCs. Do we need to go now, or can we stay and play a little bit longer to help get more of an assessment? If you suspect the patient is having a stroke, you should rapidly transport the patient to an appropriate facility. You have to give hospitals an early update of a stroke alert. They have to know we're coming in. You got to prepare for it. So give the stroke alerts. We're going to investigate the chief complaint. So again, the patient's unresponsive, gather from bystanders that they're responsive, alert, and oriented, then talk with them. Find out more about what's going on, when it happened, when it started. Last known well time. If there's no one around, quickly look for explanations for the altered mental status, such as stroke, hemiparalysis of one side of weakness, seizure, incontinence, or they've bit their tongue. In a responsive patient, ask the patient what happened. Evaluate the patient's speech as well. There we go. Gather a sample history, which we already covered. Remember that the time is critical in a neurological emergency. So again, we need to get them to the hospital. Make a special effort to determine exactly the time the patient last appeared to be healthy and collect a list of all medications and the patient has taken so far. We need an accurate med list because the hospital ones, a lot of times you'll get there, and I guarantee you guys will hear this during your clinicals. Can I get a list of your medications? Oh, the hospital already has it. So they'll tell you, right? Doesn't matter if the hospital has it or not. I need a copy for me for the transport. right? Because at least that way there you know it could be an accurate list. Because the hospital may have a list from 2 years ago, and you've changed 15 different medications over time, right? That is nothing for the hospital at all. And if when they do admittance at the hospital, they have to confirm all those medications are currently still active with the right dose, how often they take it throughout the day, and what they're actually taking. Because they have to start giving those medications to them upstairs when they get up to med surg floors and things like that. It's an odd look. I don't even want to know what she's watching. This scares me. All right. Collect all medication lists. Ask the patient if they have a history of seizures. Again, sample history, past medical history. Ask if the episode differs from previous episodes and what medications the patient currently takes. Are they on seizure meds? Are they not? Are they on glucose medication? Or sorry, blood sugar medications? Again, what are they on? What are they taking? And if not, a serious condition may be suspected here. If they're not taking glucose medication, the blood sugar is 10. Well, why is it 10 now? That's a problem if they're not diabetics. And if they're having seizures and they're not on seizure medications, why are seizures happening? Look at your physical exam. Your assessment should include your rapid assessment from head to toe. So head, ears, eyes, nose, throat, chest, lung sounds, vital signs, abdomen, pelvis, work your right down through from top to bottom. And then go to your secondary assessment, which we'll be talking about here next, where we continue looking at the entire body, paying special attention to those systems that are currently involved. If you have potential for a stroke, you really want to pay attention to your neurologic assessment, and that's your FAST CD and or Cincinnati stroke scale, and asking those appropriate questions that are there. Pronator drift, slurred speech, facial droop. Take out your phone, do your FAST CD scale, and find out what's actually going on with this patient. So do your good in detailed assessment. For vital signs, make sure we get everything. Blood pressure, heart rate, right? So pulse oximetry, lung sounds. Don't forget a blood sugar, okay? Respiratory rate. Get all the body temperature also can cause altered mental status, being hypothermic. So get all these things. If the patient is very hypothermic, guess where we need to take a temp? Rectal. I'm gonna lube it and stick it in, get a temp. Core temperatures are going to be very important for hypothermic patients or even hyperthermic, because these skin temperature things that we have in the back of these ambulances now, they are completely useless. They don't give you accurate temps. Tympanic temps in the ear are way more accurate. Oral temps are very accurate. But again, the patient is semi-responsive or unconscious and feels really cold, you've got to get a core temp. That's going to be a rectal temperature. Right? I've seen patients that have had 4 degrees difference from rectal to oral temperatures. You take an oral temp or a tympanic temp, like that doesn't seem right. They seem too cold or too warm for this. You take a rectal temp, and I've had patients that have had tympanic temperatures in the ear that have said 99. I'm like, no way. I'm getting a tan just from the heat coming off this thing, right? So I say, let's check a rectal temp, and it's like 104. I'm like, that was a difference from tympanic just to rectal. So again, now we're treating the 104 temperature. Let's start cooling them down. Or they're that cold, we got to put a bear hugger on them or warming blankets of some sort to keep them warmed up. All right. Also, we want to ensure we check their blood glucose level, and during most active seizures, it is impossible to evaluate vital signs. And this should not be your priority. If they're seizing, let them seize. There's nothing we can do until we get medications on board. So instead, protect them. Move stuff out of the way that they potentially can hurt themselves with. And in most cases, the vital signs of a patient is postictal state will be very close to normal limits. So once they're postictal, then throw them on the monitor, get all your stuff you need to do, or do your manual vitals first. For a stroke assessment, rapidly identify the stroke in the field with a stroke scale. Again, we mentioned FAST CD, or we can use the FAST mnemonic, which we'll talk about next, or we can use a Cincinnati stroke. The Los Angeles stroke scale we don't use. Again, there's all these different things: the Cincinnati, Los Angeles, NIH, Fast CD, all these different ones that are out there. I'm teaching you Cincinnati stroke scale and the Fast CD through the Joint Triage app. That's what you guys need to know. So we use a Cincinnati stroke scale, pernatal drip, facial droop, slurred speech. Three items we need to look for. Look at level of consciousness, arm drift, and motor function, and gaze. This is more of your LAG, which is your Los Angeles stroke scale that's out there as well. This is the fast mnemonic, so facial droop, arm drift, speech, and time. This is something that's been huge when they put on like hospital walls, things like that, just to kind of get awareness out there for stroke awareness. So if town offices should have this listed up there somewhere. Right. Schools can have it too, because teachers can still have strokes, things like that. So we already covered the Cincinnati stroke scale. We talked about the LA scale, which we don't even use at all. This is your LAG scale, which is level of consciousness, arm drift, and gaze. So all patients with altered mental status also should have a Glasgow Coma scale calculated. So the Glasgow Coma scale covers three things. It covers eye movement, verbal response, motor function, the three things we have to go with. The GCS score runs from a scale of 3 to 15, 3 being dead, not a 0, 3 being dead. This table has a 3, okay? 15 being all of us hopefully in the room right now, all right? Eye scale measures from 1 to 4, verbal is 1 to 5, motor is 1 to 6. And here's the scale here. So looking at the eye scale, we look at spontaneous before, in response to speech, 3, in response to pain, 2, and if they have no eye response, it's a 1. For verbal, they have orientated conversations. We can have a conversation with each other. Patients that have dementia automatically get a 4 because they're confused, okay? So confused conversation, dementia, altered mental status. If they have inappropriate words, it's a 3. Incomprehensible sounds is a 2. So grunting. And 1, none at all. Then in your motor response, obeys commands. So I can do this. I can put my arms up, my arms down. Whatever you ask them to do, they can do it. Localizing pain only. So they go like this here, and they go with that. So they move your way. Localizing pain. If they withdraw from pain, they go ow, and you withdraw, kind of push away. Abnormal flexion and extension. So there's 2 types of posturings that are out there. One is called decorticate posturing. One's called the cerebrum posturing. Both have a lot to do with brainstem as well, and herniations and whatnot. And it's also very bad. Decorticate posturing is what they call the boxer's stance. So it's like this. So what happens is your hands will curl. They'll curl like this and like that. Okay. If you see this on a head trauma patient, that's not good. That's severe brainstem injury. The cerebrum is when they come back like this and they curl out like that, and they go like this. They come backwards. So the cerebrum posturing, decorticate posturing, right? The cerebrum is worse than decorticate posturing, all right? So if they have that kind of stuff, that's significant head trauma that's causing that of some sort, or a massive head bleed. And then obviously 1 being none. So again, if you're cardiac arrest, you have a GCS score of 3. See, we don't give you a 0, you have a 3 out of it. So focus on the ABCs on the reassessment, vital signs and interventions. Stroke patients can lose airway or stop breathing without warning, right? So you got to pay very close attention to it. And interventions where multiple interventions may be necessary. So again, do we need to secure an airway, or is the airway being secured by their own? Do we have to put an OPA in, NPA in? Do we need to call for a medic for intubation? What needs to be done? And as a BLS ambulance, you need to determine what level you think you're going to need when you're transporting these patients. Most stroke patients can be handled at EMT or AEMT level. We should get an IV in place. They prefer that if you are advanced or higher, they want an 18 gauge up in the AC on the right-hand side, not the left. based on protocols. But again, if you don't have it in your BLS, as long as they can maintain their own airway, just do a 12 lead by your basic protocols and get them to the hospital. Unless they need airway intervention. Airway adjuncts can be placed. Positive pressure ventilation may also be needed, so utilizing a BVM or other kinds of treatments that you might need to use. We don't want to give these patients nitro or aspirin, not at all. Okay? This can cause a lot more damage, especially if it's sort of vasodilating clots that are already there. What that does, it pushes it in farther. So we don't want that to happen. Notify the receiving facility of the patient's chief complaint and assessment findings. Call in a stroke alert. If it's a stroke, call it in. If it's a septic patient, call in a sepsis alert. If it's a STEMI, call in a STEMI alert. This helps activate teams that need to happen in phone calls. And you want to get that early, not when you're doing a radio patch in with 5 minutes out. Call from the scene or have fire call. If you're on the ambulance, hey, command, let hospital know that we're coming in with a stroke alert. We'll call with details in a few minutes. All right, dispatch calls in, stroke alert, perfect. All right, then we know in the hospital setting, we would know that the patient's coming in with this, so we can plan to have all the equipment we need to be able to treat this patient. If there's airway compromise in the field, let them know. Hey, there's airway compromise. We've already called for a paramedic coming in, and they can start prepping. Then the medic can call in and say, hey, we need RSI, respiratory in the room, ready to go. We can make those calls and kind of activate things. But give them enough heads up. Okay, don't wait for a 5-minute radio report. They're like, because the rooms may be full, and then you have a trauma coming in. They may have to move people out to a hallway bed, get things cleaned up to get that room available for you as well. So give them a heads up notice. For critical patients, simple ones, 10-minute ETAs are perfectly fine. Communication and documentation. So obviously for patients who have hold on a minute, share the right spot here. All right, so be sure to communicate the time the patient was last seen healthy, again, the last known well time, and then findings of your neurological assessments. When you call your radio report in, say, you know, they stroke scale positive based on Cincinnati stroke scale with facial droop and slurred speech, but there's no arm drift. Okay, good to know. EKG 12 lead was interpreted by the computer saying atrial fibrillation. You can say that, but as long as you put down in your narrative and tell them computer interpretation. You cannot physically interpret any rhythm that's on there. Time you anticipate arriving at the hospital. Give them that heads up so they know. And document it. For the patients who have had a seizure, give them a description of the seizure activity if you know what it was. I mean, if you don't remember tonic-clonic, say they had full body shaking. I wouldn't say flopping like a fish on the radio, right? But let them know, hey, this is what we have. They showed full body shaking. It lasted approximately 5 minutes. Right now, they're in a postictal state. They're still unconscious, but they're breathing on their own, maintaining their own airway. Okay, not something I'm overly concerned about if I was receiving your patient, because I know that the seizure stopped. They're postictal, normal for this patient to have, and their airway is being protected on their own. Perfect. Now, you're transporting a patient, you give them a 20-minute ETA, and things change when you're 10 minutes out. Call the hospital back and tell them, hey, we just had a change in status. And this patient became more critical and got worse. If they're getting better, you don't need to call and change it, right? But if they're getting worse, they need to prep. Then document interventions as well. They also want to know for the reassessment, is there any history of status epilepticus? So again, if they have it, document, let the hospital know this is what's going on. Some conditions are easier to identify, so obviously the cause of neurological emergencies may not always be obvious as well. So again, you got to do your assessment, do your work. ED physicians determine if there is bleeding in the brain for patients with suspected stroke with a CT scan of the head. Blood clot dissolving medication may be given if there is no bleeding, and that would be the TPA that I was talking about. All right, so we already talked about those. This is how to call into a hospital. So patients who have had a seizure require definitive evaluation and treatment. So obviously, supplemental oxygen for seizure patients, if you can get them to keep it on, yes. And I'm not saying duct tape it to their face. Not a breather mask if they'll tolerate it. If they can't, guess what you're going to be doing for them? Hold the mask in front of his face. Do blow-by oxygen. Might be your only option. Protect them from harm. Maintain a clear airway by suctioning. Provide oxygen as quickly as possible. And if the head or neck trauma is suspected, provide spinal mobilization. Put them on a C-collar. All right. For patients who continue to have seizures and status epilepticus, rendezvous with ALS if possible. If you can't, your closest ALS documented is the hospital. Put in your narrative. Try for paramedic intercept, not available. Closest ALS would be the hospital. And get them quickly. Provide positive pressure ventilation as needed. Remember that most headaches or headache care are harmless and do not require emergency medical care. But you should be concerned if the patient complains of a sudden onset of severe headache, which could be what? Sudden onset of severe headaches. I know you guys are getting tired. We're not in a normal classroom. And headaches, severe headaches, one spot. Stroke, I think you said brain bleed, right? Okay. Yep, he's looking for a head bleed. All right, a sudden headache with a fever, seizures, altered mental status, or following trauma as well. Okay. If you suspect meningitis, make sure you're wearing the appropriate PPE, gloves, gown, face mask, shield, just like you would for a COVID positive patient. Assess the patient for other signs and symptoms that might indicate a more serious condition. If so, apply high flow oxygen if tolerated. Provide a darkened, quiet environment for migraines, and do not use lights or sirens during transport. It will agitate more of the headache. So kind of keep that kind of down. Migraines, if you're transporting hot, is a problem. Right? These patients are not critical, right, for any kind of migraine issue. But dark, quiet environments work really well. Hopefully the ER has lights turned down for you. I used to always, the spotlights that come down, I used to always turn that on low and turn it to a corner and turn everything else off in the room for migraines. There's just enough light so I could see to do my job so it didn't become creepy. But at the same time, though, the patient also felt comfortable because it wasn't too bright for them. Again, for stroke, support ABCs. Again, strokes we cannot fix in the field. There's nothing we can do. We need to get through the hospital to get the CTs done and then transfer to a neuro center. So again, ABC support is all we're really going to be doing. If they can't maintain their airway, we've got to maintain it for them. Use suction as needed and monitor the patients for oxygen saturations. And oxygen therapy also may not be recommended unless the patient is respiratory distress or hypoxic. We don't want to over-oxygenate these patients. If they're hypoxic, they're cyanotic, respiratory distress, or they say, I'm having trouble breathing, that's when we start applying O2. Other than that, we really don't need to do that. We don't want to over-oxygenate these patients. Paralyzed extremities will require protection from harm. Again, if they're on the scoop stretcher to pick them up, remember they can flop around, they're paralyzed, they have no movement. So as you're carrying a patient out, the last thing you want to do is have the arm down here, and then it catches the door frame and dislocates the shoulder. Right, so again, bring them in, strap them in. If you have to use, not real handcuffs, but make some fake ones to hold their arms together using a triangular bandage, then do so. I guess that's all you had. Put them on temporarily, get them up to the ambulance. I don't know what your rulings are for those. Keep the patient informed of what's going on. A thrombolytic therapy may reverse that stroke symptom on that time frame. So again, tell the patient what's going on. Keep them informed of everything that you're doing to them, because you don't want the last thing you don't want to do. The last thing you want to do is not tell them what's going on. Say you have showing signs of a stroke. We're going to get you to the hospital as soon as we can. Don't ever tell the patient they're going to be okay. So we're doing the best we can to help you, and work from there. If you're doing a blood pressure, so I'm going to put a blood pressure cuff on your arm. I'm going to get a blood pressure. For me, I would be doing an IV. I'm going to do this here. I'm going to count to 3. I'm going to do the stick. I walk them right through everything, because now they're kept informed about what's going on, so that they're not panicking inside. If I see an EKG, sometimes I'll even show them. See this right here? They're like, looks like squiggly lines. I said, me too, right? And I tell them, I said, this is what I'm seeing here. Everything looks pretty good. Your heart looks really well. Everything's going the way it should be. Electrically as well. So I tell them, I just kind of explain it to them, not in detail that I would for a paramedic program, but I would tell them in detail enough for the layperson to understand what I'm looking at. And as long as you're kept informed, you're doing your job, right? You're doing a job with that patient, and then they start feeling better. We don't want to increase more stress, right? There's a lot of traffic out today. I don't want to sit in traffic for 2 hours with you because you are seeing that you're having a stroke. So what you're going to do is you're going to hear the light, or you're going to hear the sirens, we're going to lights on. Don't be startled. You're doing okay. Everything is stable for right now. We just want to get you to the hospital. Talk them through it. Let them know what you're doing. And that will take that patient's stress level from here and bring it down to here where you want it to be. But if you don't communicate and start just doing stuff and start panicking in front of them, what's going to happen to the patient? Increased anxiety, which you don't want, increased heart rate, which you don't want, increased blood pressure, which you don't want, right? So just by you being anxious on a call, in your body language can make that patient 10 times worse, because now you've taken that patient from like a 4 to a 10. We got to bring them back down again. So explaining it helps out quite a bit. Spend as little time as seen as possible for strokes. These are not your stay and play calls. These are your get up and goes. Stroke is an emergency, and time is brain. Just like time is muscle for heart, time is brain for stroke. If possible, transport to a designated stroke center. For us here, we're going to Huggins Hospital because they are a designated stroke center that can get the CTs and the thrombolytics if needed. The patient may be in a postictal state upon your arrival for seizures. It's okay. The patient may still be having a seizure. That's when we need to start intervening. Continue ABCs, and then go for your oxygen therapy. Again, non-rebreather, 10 to 15 liters a minute on the face, and go from there. If you can't get it, you can't get it. Just do the best you can. The seizure, if it's difficult to safely prepare a patient for a transport who is having a seizure, they're actively seizing, try picking them up. It is very difficult. Sometimes they may need to, if you can't break the seizure, you need to bring the stretcher into the house. You're on the second floor. We have to get them onto a backboard and strap them down to get them out. But what do they always tell us? Don't ever strap a seizure patient down. So how do we get them out of there? Reeve sleeves work pretty well. We're not strapping them. We're just putting them inside a big orange burrito and bringing them down the stairs. But we got to break that seizure. So if the patient's having a seizure upstairs and you have ALS coming, wait. Get the paramedic up there, give the medication to stop that seizure, and then transport. Now, for BLS providers, if the medic gives a medication and the seizures stop, that medic has to transport with you. They cannot downgrade that call to BLS. And there are some medics out there that will try to do that to get out of having to do a transport. Okay, they have to come with you. Not every patient who has had a seizure wants to be transported, and that's okay. Your goal is to encourage the patient to be seen by a physician, but be prepared to discuss the situation with hospital staff. What they're saying is the patient doesn't want to go, bring up medic control, have a conversation with them. Remember, consultation is not a bad thing. We're consulting with them to find out what we want to do. If the hospital physician says, they don't want to go, they're alert and oriented, they don't need to go. Right, doc, what's your name again? Perfect. Right, then repeat back the order. We're okay to sign off patient refusal against medical advice. Your name is this, and that goes into your narrative. Per Dr. whoever, Dr. McCarthy over here, states that the patient does not need to be transported to the hospital as long as they're alert and oriented and able to answer all questions appropriately. Type it out. That's in your narrative. They sign off. Family member or law enforcement can witness it, and then you go on your way. We want to make sure you have all that stuff documented appropriately. But the patient has to be alert and oriented to person, place, time, and events. They have to know what's going on before you can do a refusal. Signs and symptoms may vary from simple confusion to coma with altered mental status. And this could appear as intoxication or even a minor head trauma with altered mental status, but this requires immediate attention. What's causing it? If you check a blood sugar and all your meter says is high, it's not saying hello to you, right? That means that it's higher than your meter can read. And some meters stop at 800, some stop at 600, and it's higher than that, right? So they could be in what they call HHNC, which we talked about during diabetes. or they could be in diabetic ketoacidosis. They could, who knows? Again, it's high numbers. When we see that kind of stuff, these patients need to be rapidly transported. Even paramedics, there's nothing we can give in the back of the ambulance other than IV fluid, saline, to dilute the blood. These patients need insulin quick. All right. And we don't carry insulin in the ambulance. Nor do you assist the patient with theirs. Oh, they're unconscious and their sugar is 800. We draw them out of the vial and give it a sub-Q. Yeah, don't do that. I always tell everybody you can do everything once. But after that, you're probably not going to have a license anymore. All right, so looking at review, a 41-year-old man presents with slow, irregular breathing, hypotension, and dilated pupils. These are signs most likely indicate dysfunction of the brainstem, the hypothalamus, the cerebrum, or the cerebellum. Irregular breathing, what controls? Remember I mentioned before. Everybody agree? Right. There's no hidden messages now on there. Everybody said tell me what it is. All right. A, it is. Good job. An acute ischemic stroke is caused by good. D, it is. A 56-year-old man experienced a sudden severe headache and then became unresponsive. He has a history of high blood pressure. The most likely cause of his condition is very good. Not bad. 3 for 3. Unlike an ischemic stroke, a transient ischemic attack, TIA, is characterized by all the following except, I heard B. All right, 4 for 4. A patient with a suspected stroke presents with a slurred speech that is difficult for you to understand. This is referred to as I heard D. Everybody else agree? I heard 1. I see an A. I hear a D. C. Any other guesses? Well, what is it, Gabriella? D? D it is. Good job. So glad I'm recording you. A type of seizure that is characterized by severe twitching of all body muscles and lasts for several minutes or longer is called. Oh, it was D. It's okay. The most important reason for properly transporting a stroke patient to the hospital is C. All right. It was B. Oh. The answer is B. Number 8. Which of the following are components of Cincinnati pre-hospital stroke scale? A, B, C, or D? Good job. C it is. Number 9. Your patient opens his eyes when you say his name. He is making incomprehensible sounds and withdraws when you pinch his earlobe. What GCS score does he have? A? 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 Good job. And the last one, if a patient complains of severe migraine, how should she be transported? All right. I like it. We're going to go with C though, okay? It's okay. Good job though. You got a couple right.